really excited to have you all here today. Meet you virtually, I guess, and sort of we can talk about hip pain and what we do at Stoughton Health, and I'll sort of introduce myself. I titled the talk "Hip Pain," but it's more going to be a sort of general overview of how people live their life with pain, and then what we can do what we can do both operatively and non-operatively for it at Stoughton Health, and I mean nationwide. But so. Let's see if I can't. There we go. So I'm an orthopedic surgeon. This is just, I put this in here as a slide just for me to introduce myself because I'm sort of new to the area. I am actually a UW-Madison grad. I was born and raised in Menominee Falls, Wisconsin, and I've been out of the state so long that I'm used to explaining that's near Milwaukee. Nobody really knows where that is when we're out of state, but a lot of people in state know where Menominee Falls is. As long as you don't confuse it with Menominee, which is up northwest. But Menominee Falls, suburb of Milwaukee, born and raised there. And then I came over to Madison, did undergraduate and med school training here in Madison at UW. From there, after I got my engineering degree and my medical degree at UW-Madison, I went over down to Dayton, Ohio at Wright State Orthopedics and did 6 years of training down there to become a surgeon. And then I moseyed on over to Louisville at the University of Louisville. And there is where I did my fellowship training. And then I come back here, coming back home to Madison to start my practice up at Stoughton Health, which has really been a great experience over the past few months. I think that a lot of people are surprised to hear how much training surgeons do, but in total, if you count med school, it's about 10 to 11 years of training that we do, and then we can start our practice. So I'm really excited to be home here at Stoughton Health and uh, providing the orthopedic care that I provide. Now, what did I learn how to do? I learned specifically orthopedics, but also more specifically, I subspecialized in hips and knee arthroplasty. So my subspecialty is called adult reconstruction. And adult reconstruction in the orthopedic world means we replace hips and knees. So I do hip and knee replacement. But I also do revision or second time surgery for people who are having issues with any of their joints that have already been replaced. If you have an artificial joint and it's hurting, I spent a year down in Louisville learning from some of the smartest and brightest down there, really surgeons that are known nationwide for how they do revision surgery. So primary and revision surgery of the hip and knee is my subspecialty. I also do some trauma, so hopefully nobody breaks their bones, but I am very well versed in how to fix broken bones as well. So the that is sort of my training and where I come from and what I do. I think we're going to talk a little bit about who we are at Stoughton Health in case you don't know us. My name is Dr. Henningsen. My partner is Dr. Ravel. He's much more established. He's been in the community for a little bit longer than I have. He does a lot of sports medicine. He does knee surgery as well, and he does shoulder surgery as well. So that's sort of his subspecialty in the field of orthopedics. And then Dr. Lind is foot and ankle surgeon podiatry trained. So he can sort of subspecialize in the region below the knee. So between the three of us at Stoughton Health, we actually sort of have the gambit of orthopedic care from the shoulders, knees, hips, and toes. So hopefully, and we all have our own sort of niche that we take care of, and we overlap a little bit with Dr. Ravel and I, but that way we can provide the community of Stoughton sort of comprehensive orthopedic care as needed. So really excited about all of our new facilities at Stoughton Health, and we do have some new toys that we use in the OR, like the robot that you may have heard about, and some new muscle sparing approaches that I brought from Louisville to make people recover faster. But honestly, in the end, we're just trying to make sure we know what's going on with our patients, treat them well, get to know them, and then get them back to doing what they want to do. So that's us at Stoughton Health, and we can sort of dive into the hip and what is the hip and how it might hurt you or affect your life. And I think that One of the struggles that a lot of people have is what is the hip? You point to your hips, you sort of point to some people point to the outsides of their hips, some people point to more of the buttock region, you know. It's not it's a joint, and sort of in the non-orthopedic world, the hip joint is everything in between the spine and the leg. So it involves the pelvis, it involves the lower spine, and it involves the femur. Um, Trying to simplify it down, the hip itself is a ball and socket joint. The hip is where the femur, which is the largest bone in the body, that's your thigh bone, where the femur at the very top of that hip, at the very top of that femur is where it articulates and touches the pelvis. So the joint is where your femur bone, your thigh bone, meets your pelvis. Okay. Your pelvis is a ring of bone, very complex ring of bone. That is what connects to your spine. So I mean, we're very familiar with the skeletons this time of year and Halloween, but the spine connects to the pelvis. And actually, the very bottom of the spine is called the sacrum. You can see it in the picture there in the middle below the spine. That's the sacrum. The sacrum is actually part of both the spine and the pelvis. And then the hip is where the thigh bone meets the pelvis. Complex sort of anatomy in terms of the three-dimensional structure. And the reason why this is all so important is because when people say they have pain in their hip, it can mean a lot of different things. It might mean, it hurts to lay on my side. It might mean I have pain in my buttock. It might mean I have pain in my groin. It might mean I have pain in my pelvis. So all of that, if you say my hip hurts, any one of those things can be where it's coming from. So trying to differentiate that is sort of my job, and what I really am going to spend most of my time today talking about, because um, I think I want you guys, as sort of our patient population, to be educated about where your pain is coming from and then what we can do to help. Because it starts with the diagnosis, right? It starts with what is going on. And that obviously starts with anatomy, and we build from there. We got to have a good foundation. So that's the skeleton. What are the hip muscles? All right. There are a lot of muscles, obviously, but I will propose to you, everybody, today that the most important muscles of the hip are what we call the hip abductors, AB abductors. And everybody sort of is familiar with the term gluteus maximus. That's that meaty portion of the buttock. Um, but that gluteus maximus is not actually the most important muscle in the hip. Far more important are two other muscles, which we call the gluteus medius and the gluteus minimus. Lots of fancy words, lots of medical terminology. But I know that Dr. Ravel has given some shoulder talks, and one of the things that I say in clinic is these hip abductors, these gluteus medius and minimus muscles, are what we would sort of the analog is the rotator cuff of the shoulder. This is the rotator cuff of the hip. These muscles are the muscles that stabilize our hip joint. These muscles are the muscles that we use in order to stand upright and walk without what we call a hip drop or Trendelenburg gait. If you see somebody who has a hip drop gait, usually that is because these muscles are either injured, torn, or not working. And so just like knowing the skeletal anatomy is really important, if you know what are the two muscles in the hip that are the most important muscles in the hip abductors are the two most important muscles of the hip. And as you can see, these muscles attach way outside of the ball and socket joint. These are not the ball and socket part of the hip. That's more to the ball and socket is sort of that osseous, bony anatomy. This is sort of the muscular anatomy of the hip, and they help us walk straight without the hip lurch. So understanding what it means when I say hip is so important, and what patients mean when they say hip is so important. The reason why I go into all these things is because each different area of what I've described as the hip can cause pain, and each of them, if that's the pain generator, there's different mechanisms in how we treat those. So moving forward, and then I guess the last thing I wanted to reiterate is that the hip and spine are very closely related. Yes, the femur meets the pelvis, but as we talked about, part of the pelvis is actually the bottom of the spine. So the pelvis, the thigh bone is connected to the spine through the pelvis, and in the lower spine, any nerves that are pinched in the lower spine actually can cause leg and hip pain. So this is where the confusion gets, and the artistry of figuring out what's going on can be tricky because we have muscles that can be pain generators, we have the joint that can be pain generators, and then we have the spine that can be pain generators. And any one of those going on at one time can cause pain. And as we all know, they're all connected. And as we all know, that sometimes there are multiple things going on at once. So some people have back problems and spine problems and muscle problems all at the same time. And we got to figure out which is the most important and which one is the one that will most benefit from intervention. Or maybe we got to treat them all at once. And that's what I do in my clinic. So in my clinic, I'm very commonly getting both hip and spine imaging. And although I don't do spine surgery, I very commonly will be getting spine x-rays and spine MRIs in order to figure out what is going on. So even if I'm not going to be able to the person to provide the treatment, I can have enough information and have the diagnosis before you even get to a pain or a spine specialist. So, because the hip and spine are so related, even though I'm not a spine doctor, the spine is super important to talk about and learn about whenever in any discussion with the hip. And so there's just another illustration, and it's a busy slide, but I'd point you to that the left side of the screen where those nerves in your back become what they call a conus medullaris and a cauda equina. Cauda equina literally means horse's tail. You literally have a horse's tail of nerves in the back of in your spinal cord, because your spinal cord actually ends at the very, very top of your lumbar spine. Everything below that, which is L1, we number things. Your lumbar spine, L stands for lumbar. There's 5 of them. And on L1, on the top floor, that's when the cord actually ends. And everything below that cord is just nerve roots and that horse's tail of nerve roots. And all those nerve roots go to your hips and legs. They don't go to your thorax. They don't go to your belly. They go to your legs. So if you have pinched nerves in your spine, it can cause pain in your hips, legs, even all the way down to your feet, so sometimes spine pathology presents with leg pain, a little bit counterintuitive. There's a lot of things in orthopedics and medicine that make sense. Like when I say it's all connected, one affects the other, that makes sense. Anybody can sort of understand that. One thing that's not super intuitive, you can have back issues that cause leg pain. There's anatomical reasons for it, but it's a little bit confusing because if we say, well, my hip hurts, why are we talking about my back? It's because the nerves start in the back, and that's where the pinched nerves are. So in my clinic, we are talking, if you have any type of hip pain, we are often talking about how the hip and the spine are related, how the hip is related to the knee. I am somebody who says it all affects each other, right? If you have hip pain, you might end up having knee pain. If you have back pain, you might have it's all connected, and that makes sense. But there are tricks and tips about some simple ways to sort of determine which is the biggest pain generator. And that's what I'm going to try to get into in the next 15 or so minutes. Now that we sort of have our base of what causes hip, what is the hip, and the top 3 sort of causes of hip pain. This is just a slide I gave a hip talk during my fellowship specifically about how the spine is related to the hip. So I'm sort of like the expert in my fellowship on this. And this is just showing that in order to get your shoes on, this is the skeleton of a patient who's bending over to put their shoes on. And it's just illustrating how much spine motion you have to have in order to do that and how much hip motion you have to have in order to do that. So, I mean, we all put our shoes on every single day. So if you're having issues with your back or your hips, it can be difficult even to get dressed in the morning. This is a very significant pathology that affects our patients every single day. And understanding how we can best treat it and relieve some of our patients' pain is really going to get them back to doing some of the most basic life functions. And it can be really satisfying when somebody says, I have difficulty even touching my toes, and then we treat something that I'm feeling so much better. So it's just an illustration of, again, not only the relationship between the spine and the hip, but also how important it is, how it's all connected, and how we use it to do the most basic things in life. So, given all of that, how do I know where my hip pain is coming from, right? So, the three main things that I see in my clinic are going to be it's coming from the joint itself, truly that ball and socket joint where the thigh bone meets the pelvis. It can come from those muscles, the rotator cuff of the hip, or it can come from the spine, the back, and those nerve roots. So it's really, again, the three main causes of hip pain. It's the ball and socket joint, it's the rotator cuff of the hip, or it's the nerve roots. And it's really my job in order to figure that out. And what's amazing is really you can usually do it without too much imaging at all. Obviously, we're orthopedic surgeons. We love our x-rays. We love our MRIs. We like to get imaging to help. But a lot of patients tell you what's going on before you ever look at the x-ray or before you ever look at an MRI. They'll be able to tell you what's going on based on purely their symptoms and how they're walking. So really, it's so important to get to know me, and I need to get to know you when you're in the clinic with me because without knowing and hearing where you're having pain and what it's coming from, I won't know no matter what the imaging shows. It's you guys tell me really where the pain is coming from, and I'm going to tell you the tricks, right? There's no secrets here. So what is the joint pain? So the joint pain is groin pain traditionally, okay? When I say that, I would say about 60 to 75% of patients with ball and socket arthritis have groin pain, okay? What about the other quarter of patients? Those patients have buttock pain and thigh pain and sometimes even knee pain. About 10% of patients with hip pain present with knee pain, with hip arthritis present with knee pain. Again, that sounds counterintuitive, but when we go back to it's all connected, right? It's all we like to separate them into boxes, but we are a human being that everything operates together. So about 60 to 70% of people will point to the groin when it's a hip joint issue. And I mean the slam dunk, the gold phrases are if you have pain putting your socks and shoes on, it's almost always an issue with the hip joint itself. And I know I showed you that picture where it's like, the patient's bending over and it's the back and the hip itself. But, sometimes you put your socks and shoes on by bringing your ankle up and putting it on your knee. Well, if you can't do that, that is very commonly coming from the ball and socket joint itself. That is arthritis. That is hip pain that's coming from arthritis. Same getting in and out of the car. This is something we do every day again, right? I can't get into the car, doc. When I get into the car, I have to sit down and I take my hands and I lift my leg into the car after me, right? That is a hip joint issue. That is my joint isn't moving. My ball and socket joint isn't moving. And those two things are so important because one, they're very specific for it's coming from the joint. And two, you do them every day. So if you're having pain when you're doing those two things, this is severe arthritis. This needs intervention. This is not something you can just grit your teeth and, tough it out. I think I've been in the Stoughton area now for a little over 2 months, and I feel like there's a lot of those people out there who say, I've been toughing it out. We have a very tough Scandinavian population who just likes to sort of grit their teeth and bear it. But like if you're having trouble getting your socks and shoes on, if you have trouble getting in and out of the car, you're doing these things every day. This is severe issues and we can help you with it. And it doesn't mean surgery. I'm a surgeon and I love to do surgery, but it is a last resort. We can help you with this in other ways. Your hip abductors are probably the most common cause of pain of all hip pain. And it's the reason why people think it's the hip is because, doc, I put my hand on my hip and it hurts. I lay on my side when I'm trying to go to sleep and it hurts. I can't lay on my side. When I'm walking, my hip drops. It's got to be my hip. It is. It's not the ball and socket joint. It's the hip abductors. And it's a spectrum. Some people may have heard the term bursitis or trochanteric bursitis, which is very common, but on that spectrum is actual tears of this tendon and actual tears in the muscle that doesn't respond to therapy or injections. So we start with easy things, but this can be just as severe of pain and just as limiting of pain as the arthritis pain. And differentiating the two is really going to be, I can't lay on my side. It doesn't hurt too much when I'm getting in and out of the car, but I can't lay on my side. Those being able to differentiate that will be able to give us where we go from a treatment standpoint. And then the spine, not a spine talk, but it's so intimately related. So I want to be able to talk about it and touch on it. The shopping cart sign is a classic sign described in I think it's 60s, but people who lean over a shopping cart when they're at the grocery store and they're leaning over and that feels better, that's very commonly actually a spine issue, not a hip issue. Again, it can be buttock pain, it can be groin pain, but if they lean over and it gets better, that's actually you're opening up that canal and taking pinching off of those nerves. So if we were to do hip procedures on you, you wouldn't get any better. And I've seen it happen. It's surgeons can get tunnel vision, which is why I try to teach people, but also this is why I get spine imaging in my clinic. I need the diagnosis and I need to know what's going on before intervention. So I will be, if I'm worried about your spine, I'll be getting spine imaging in my clinic. So um, I think a good hip surgeon knows about the back and is able to at least diagnose the back as well. Yeah, shooting pain all the way down the legs, numbness, weakness, tingling. These are nerve problems, not as much hip problems, but you'd be surprised how often they overlap. So, how do I treat the pain? And I talk a lot, so I'm running out of time here. So, first and foremost, we treat without surgery. So my plan A, plan B, and plan C is not surgery. Surgery is a last resort. It is plan D. Okay. So what does that mean? First and foremost, exercise and physical therapy. I'm a huge believer in exercise and physical therapy, and I'll give you a quick 5-minute pitch about it. The reason why I'm a believer in physical therapy is because I grew up an athlete. I played a lot of sports when I was in high school. So did my whole family. I have 3 brothers, and I even have a brother who plays in the NFL. Okay, so we very big, high athlete family. Now, if you injure yourself and you have something wrong with you as an athlete, the first place you go is the trainer. You don't go to the doctor, you go to the trainer. The trainer gives you exercises for your joint that hurts. And these are the biggest and strongest people in the world, right? You can be the strongest person in the world. Doc, I'm going up and down ladders, cleaning gutters, working in the yard. There's so many people who own farms, right? Yes, you're active, but the biggest and strongest people in the world go to the trainer first and get exercises first. Because again, you subconsciously are protecting your pathology. You're subconsciously getting weaker, even though you're staying active, even though you're toughing it out. So go and do exercises dedicated for the joint that hurts. I'm a big believer in it. And the reason why I'm a believer in it is because I was an athlete. And I know some people aren't athletes out there, and that's okay. I use that a lot, sort of my experience, as a way to explain, my brother squats 600 pounds, but if he hurts his knee, he goes and he starts doing exercises for his knee, right? He's 600 pounds. That's plenty strong, but he needs to work on it because he hurt it. So big believer in exercises. Anti-inflammatories like ibuprofen, Aleve, there are prescription anti-inflammatories we can use in the clinic are also super helpful. They're designed for arthritis. Arthritis means joint inflammation. Arth means joint. Itis means inflammation. So inflammation, what is inflammation? It's a black box, right? Well, inflammation is your body's response to injury. Okay. So if I jam my finger, if I twist my ankle, it swells up and it hurts. Well, that swelling and that pain is from the inflammation itself. Okay. So people who have chronic pain oftentimes have chronic inflammation because their body thinks something's injured that isn't. So an anti-inflammatory directly turns off that response. An injection is just a stronger anti-inflammatory. We use a steroid, which is the strongest anti-inflammatory on the market, to shut off that response. There are other injections like PRP or what's called hyaluronic acid or These are things that are used to try to make the joint healthier. None of exercises, anti-inflammatories, or injections change your imaging. Okay, they don't change the way the X-ray looks, but they can treat your symptoms and make you feel better, which is what we want to do, right? We just want to be able to go put our socks and shoes on. We just want to be able to get in the car. So I do ultrasound guided injections of the hip in my clinic. So if you're saying, I don't want to have to go to a surgeon and then a different pain doctor just to get an injection, I'm a one-stop shop for the hip. Okay. And then surgery, I have a picture of a total hip arthroplasty there. That is sort of what I do. I'm a surgeon, right? That's where we go in and we take out the joint that's diseased and replace it. That's the only way to change the X-ray. That's the only thing that once you recover from it, the pain doesn't come back. It's a wonderful, wonderful surgery. It's my personal favorite surgery. It has a very, very high success rate at 97 to 98% satisfaction. So I am a huge proponent of total hip surgery in the right patient. But again, it is my plan D. Um, I can talk a little bit more about exactly how I do that procedure and everything. I'm running out of time a little bit, but what I will say is a common question is how long do these things last? Okay. Well, in today's world, our all of our implants are 3D printed to match the porosity of bone so that the bone grows into the implant, and that's a lifelong bond. As a revision surgeon, I can tell you those are hard to get out. That's a lifelong bond. And then our plastic that we use, so metal can't touch metal. So our plastic that we use that's in between the metal is a third generation plastic that was designed in the late 90s. It's been used since the early 2000s. And before then, the plastic used to wear out in 10 to 11 years. We've been using this plastic for consistently for about 21 years, and we haven't seen it reliably wear out. The plastic is probably the weak link. The plastic will probably wear out at some point. It's a material just like any other. We just don't know how long it's going to last in people because we put it in 21 years ago. We can do testing in the lab, but the real the real way to tell how long it's going to last is when it starts wearing out consistently in patients, and we haven't seen it yet. So right now, today, I can confidently tell you that our implants, given no complications, should last at least 21 plus years, hopefully, in an ideal world.